Well, good morning, everyone. This is Mike Hill of Total Control Health Plans and Colebrook Insurance, and I'd like to welcome you to our webinar this morning, focusing on the future of healthcare post-COVID-19. Pretty excited about the panel of speakers we have for you this morning. I'm joined to my left by Congressman Bill Huizenga, who represents Michigan's 2nd Congressional District. We've got Dr. Rakesh Pai, who's the president of the medical group and chief population health officer at Metro Health, part of the University of Michigan Health System. We have David Contorno, the preeminent benefit consultant in the United States, and myself, and Mike Hill, the founder of Total Control Health Plans. We've got a great agenda for you this morning. We're going to ask Congressman Huizenga to give us a legislative update. There's been a number of activities in DC going on over the last couple of years and to address healthcare costs in particular, and we're going to ask him to give us an update on progress in those particular areas. I'm going to turn it over to Dr. Pai to give us an update on the impact of COVID-19 on healthcare providers and what it means for the future. We're going to ask David Contorno to focus on action employers can take right now to have a meaningful impact on their healthcare plan. And finally, then I'm going to wrap it up. So with that, we're going to turn it over to Congressman Huizenga and let him kick off our discussion this morning. He does need to depart at 11 a.m. sharp to head to DC to take some votes tomorrow. So we're going to give you the opportunity to submit some questions through the Q&A session on the Zoom app. And we'll try to get 1 or 2 questions to him before we turn it over to Dr. Pai and we dismiss Congressman Huizenga to hit the road. So, Congressman Huizenga.
Hey, thanks, Mike. I appreciate it, and really good to be with you all. And yes, this has been quite a journey we've been on as a country, starting with COVID, and then obviously with the social unrest that we've been all witnessing in various parts of the country and various parts of our state. It's been a challenge. It's been a challenge for all of us as citizens. It's been a challenge for business. It's certainly been a challenge for those in the healthcare system, and we're attempting to try to deal with those things. You may have noticed, and I'm sure this is not much of a shock, but you may have noticed it's an election. So there are some strange things that happen in election years anyway, and so a strange year just got a little stranger, and you know, these are very serious issues that we have to tackle, we have to deal with as a society, as a community, but there is some politics that's getting played, and I'm sure everybody's shocked at that. But couple of I guess maybe a couple of things, a little background excuse me, on what we've been doing. There's been a lot of discussion about healthcare transparency for a very long time. And in fact, I was telling Mike when I came in, I was a fairly new elected member of Congress it was probably about 2012, when my former governor, then head of the National Association of Manufacturers, John Engler, came into my office and wanted to talk. I was on the Financial Services Committee, didn't want to talk about that. I'm from Michigan. He didn't want to talk about that. He wanted to talk about transparency in pricing, and he wanted to talk about what this meant for his members. So that was sort of the kickoff in many ways for me having this discussion, and it's one that's been ongoing through last administration, this administration. Certainly when the Republicans were in majority, the Democrats have been in majority. It's been an issue that many have realized we needed to do something about. And that is going to be an ongoing issue. Now, set aside your feelings of President Trump and love him or hate him, like the administration, don't like the administration. On this particular issue, he has been going some places where, frankly, it hasn't been gone in previous administrations. He's been sort of forcing the issue to the forefront, and I think that's a very positive thing. And we were again talking just before we came on. 2 of the actions. One of those was dealing on the transparency front. Health and Human Services (HHS) finalized a rule regarding the hospitals to post pricing information. Actual payments hospitals receive for the hundreds of services they provide. That was exactly what Engler was talking to me about back in the day. And having that ability to understand not only what you're paying, but what others in your industry or others in your regional area are paying, seems to me to be vital information, very important information. So that was one. The other was the idea of having commercials, drug commercials, have to post information about their pricing on there. That had been shot down, or has been shot down in court recently. There's probably going to be some appeals on that. Probably going to be appeals on. You may have noticed we like appeals and lawsuits here in this country. But there's at least some movement. There's at least some movement on that, and that's going to be important. Surprise billing. Surprise billing has also been a significant issue that we've been talking about, and not well, not in a superficial way, in a meaningful way. And we've come close on a few different times to have some of that language and some of that consensus language put into bills, including the last CARES Act bill, which was the very large, about $2.5 trillion that we had done. That was with a T, by the way, 12 zeros behind that. But that hasn't quite made it. There is some discussion as if there is going to be an additional bill, whether that's included. Maybe just a recap, we have had 4 bipartisan significant phases that have been signed into law and have been implemented so far. The first one going back all the way to March 6th. And I literally remember sitting on the House floor debating with some of my colleagues whether $8.2 billion was too much, or maybe about right, or maybe not quite enough. You know, quite honestly, that's rounding error with what we've been doing. It seems like a quaint little $8.2 billion, but that was very quickly followed up, because that was on March 6th, and then on March 18 we did another $100 billion plus, and then it was March 27. So within the span of 21 days, 3 weeks for Washington, D.C., which can't collectively tie its shoes in 3 weeks, ended, Dr. Pai's nodding ahead very vigorously. You know, we can't collectively tie our shoes in 3 weeks, but we were able to spend nearly $3 trillion. It was about $2.9 trillion. And then there was a follow-up regarding the Paycheck Protection Act. One of my goals was to, 1, make sure that individuals were taken care of, 2, make sure that small business was taken care of, and 3rd, we had to look at the overall general economy, and that was Paycheck Protection Program, but it was also the Main Street program and others that some of you may have participated in. So there was those were the 4 phases. There was a 5th attempt by the House. I would characterize this as a little more on the political side, since Speaker Pelosi never included our leadership in the discussion, nor was there ever a hearing in any of the committees. But the House passed a $3 trillion literally grab bag on everything and anything that was on the shopping list. That isn't going anywhere, wasn't going to go anywhere. We knew that at the time. Speaker McConnell, and I think rightfully so, I agree with him on this, and many of my other colleagues have said, look, let's get the money deployed that we currently have out. And that was money to hospitals. There was I believe it was $150 billion that went out in total, or at least was allocated, hadn't gone out in total yet. There's a number of other states like Michigan, which have not fully deployed the money that they have received. Michigan got about $3.8 billion. They're sitting on it. It wasn't until last week they finally had an agreement. I think they were spending about $880 million of that between the House, the Senate, and the governor. The governor had literally just refused to spend any of that money, wanting to hoard the cash and look for a rainy day fund. You can't keep going to your broke uncle who says, okay, yeah, I'll put it on the credit card. These are difficult decisions that we are all going to have to make, and we're moving ahead with that. So yeah, I guess maybe that's kind of where we're at. Transparency, surprise billing, drug pricing, with what has been happening in the courts. We'll see what's going to be going on there, but how about we stop there, and if we've got questions, or if you've got something I need to explore a little more, happy to do that too.
Awesome. Thank you very much, Bill. So one thing you touched on in a question that we had submitted from one of our viewers, can you help us understand how likely do you believe a fourth stimulus is going to be? And some of these key things that we've been trying to get done, as you mentioned, grab bag, things like pricing transparency, surprise medical bills could be lumped into that. What is the likelihood that you think we might see movement on that?
Well, so there are no active negotiations happening. We've been told that that probably won't begin until really the 4th of July. As Mike said, we're going back, the House is going back to Washington today. We'll be there for votes Thursday and Friday. We then come back early Monday, and we're there Monday through Thursday through the 2nd. That was a little unexpected. That was a change in our schedule, but we're trying to just bob and weave like everybody else here. We do it a little less nimbly than business does, but nonetheless, we're trying. We're then in the House. We are then out for 2 weeks, not going to Washington. There's an attempt to kind of get the House in and then the Senate in and sort of alternating, so we don't have quite as many people at the Capitol, and certainly for staff, for cleaning, for all those things that has to happen. So the House doesn't come back until the week of the 21st, I think it is, whatever that Monday. And we're in for 2 solid weeks, the last 2 weeks of July. Is it possible that something gets done? Yes, possible. Typically, the faster you do it and the larger it is, the more mistakes and the more unintended consequences there are in that. I'm sure you're all shocked about that as you're doing your own business planning, right? But there is a need to address some issues, and if nothing else, just to sort of clean up some of the other programs that we have out there right now. Will there be additional stimulus? I'll use air quotes around stimulus because there's different definitions of that. Does that mean people are going to get another $1,200 direct payment? Less likely, but possibly. Is there going to be some sort of phase out of the $600 kicker on unemployment? Very possible. Is there going to be some incentive to get people back into the workforce? Absolutely. I hear from employers all the time here in West Michigan that one of their biggest challenges is getting people to come in who are making more money while they're on unemployment than they would normally. I had a small restaurant owner tell me that his entire kitchen staff had ghosted him and wouldn't return email, text, or phone call. And he said they're going to be surprised when they come back in July and their job isn't there anymore because I hired somebody else. Now he's in the process of trying to hire somebody else and struggling a little bit with that. But there's a lot of issues. There's also, frankly, a huge issue that's going to have to get hammered out is liability. Liability for businesses, liabilities for schools, for hospitals, you name it. It is the liability question is a huge one. There has been some limited liability that has been granted. This is a characterization, but I think is accurate. For the most part, the Democrats don't want to expand that. The Republicans basically do. We want to cover business. We want to make sure that if you're going into a Meijer or you're going into a retail store, that somehow that shopping experience doesn't qualify you to get into line for a lawsuit, and without some sort of gross negligence happening. So there's those issues are all going to filter in and factor into that. The good thing is that, like with some of the transparency issues and the drug pricing issues, they've been close and in the past. And what often happens is you'll have these issues kind of stack up, and then it'll just tumble very, very quickly. It's like the dam will burst, and suddenly it'll have drug pricing and North Korean nuclear technology transfers all in one bill. So some things that maybe aren't necessarily tied together logically, but so there is that possibility. Just with this layered on political aspect, everything is political. Declaring today Wednesday is political these days. Somehow it has been very tough to negotiate through those things when people are more focused on an election and trying to get somebody in or somebody out But we'll,
Mike, can I ask the congressman a question?
Absolutely, David. And before I turn it over to you for the final question for the congressman, just in a lightning round format, Congressman Huizenga, if the employers on this call are waiting for Washington, D.C. to fix things related to healthcare costs and healthcare quality, should they look for alternatives?
He's sitting right here. Yeah, I mean, and that's there's a limited amount that frankly we're going to be able to do in a limited amount of time. And look, business needs to have this happen sooner rather than government can provide that. We typically don't lead; we tend to lag, and so it's helpful to see industry move in a direction. Now, having said that, again, with some of the actions of the administration, I think that they hopefully will be forcing a few of these issues. But it is always better if we can get some private sector solutions out in this.
David, we'll have you ask a question,
Yeah.
then we're going to turn over to Dr. Pai to offer the perspective of the healthcare providers.
Perfect. So Congressman, we talk about surprise bills, and what we're really talking about, as it's mentioned on the slide, is when someone makes sure they go to an in-network surgeon and an in-network facility, but their anesthesiologist or their radiologist is intentionally not joining the network, because why should they agree to a discount when you don't get to pick them anyway? But here's my question. I have two questions. Question number one, isn't every single bill in healthcare a surprise bill, since neither the provider, the insurance company, or the patient know what the cost is going to be, whether you're in network or out of network? That's question number one. And question number two, if you really study what a network is, it's one of the biggest reasons why we have lack of transparency. And so if a bill passes that protects people when they try to go in network but accidentally go out of network, aren't we further protecting the very networks that have caused all the problems that we're dealing with today?
And my guess, David, is I think you've answered your own question, and absolutely that's why we're here today. So,
Yeah, I think that's a fair characterization, though. I mean, look, that's why we all have insurance, right? Whether it's life insurance or health insurance or car insurance, you have to be prepared for the unexpected. And there's only so much preparation you can do. But when I get my car insurance, I have a reasonable expectation that when I have the fender bender or the deer jumps out in front of the car, a very Michigan thing, right? I'm going to be able to have those repairs, and regardless of which shop I go to, it's going to be reasonably within the same amount of money. And now my insurance company might say, well, we don't want you to go to X, we need you to go to Y, because we've got to deal with them. But when I go to have my car repair and they tell me that they just also repaired my boat and they're going to charge me for that gets a little like, huh, where'd this come from? So we're very fair, I think, characterization of that, David, and that is certainly some of the things that we're trying to tackle.
But there's one big difference. When I fix my car through insurance or I fix it through cash, it's about the same price.
Yes.
When I get an MRI through insurance, it's about $4,000. When I pay cash for an MRI, it's about $400. So the bigger problem with insurance is it doesn't reduce costs. It dramatically inflates cost, and it is doing us literally no good. And I will also point out that health insurance is the only insurance in the country that people go bankrupt when they use it, whereas the primary purpose of insurance is to prevent bankruptcy and catastrophic financial loss. So I'd love to talk with you one day, because I feel like there's a lot of things. Politicians think insurance makes things cheaper. They protect us from large claims. That's not what it does. It actually quite does the opposite. It increases the likelihood of large claims and makes all claims cost more than they need to.
Yeah, if you don't mind, this is an important issue. And the example I use, frankly, so many people come and they go, I don't know the difference between an X-ray, an MRI, or a CT scan. All I know, here's my copay, right? And so there is very little skin in the game. There's very little understanding. And I know that's why a number of, at least companies in this area, have self-insured. Because they really do want to know and need to know what those actual costs are. The same thing needs to happen for us as consumers of it, to have a better idea of what those actual costs are. I like the idea of HSAs because then you are more in control and you start making decisions about where you're going to go based on some of those costs. I think that is extremely important to understand that. In all full transparency here and in fairness, I've got family members that are in healthcare. My brother-in-law is a PM&R doc. My sister-in-law is a nurse who also is the office manager for a family practitioner. I've got a cousin who's a PA. I've got her son is an emergency doc. We've got a number of nurses, number of doctors, number of healthcare workers in nursing homes. My sister was a physical therapist in nursing homes. They're all frustrated with the system. They're all frustrated with not knowing what they're getting paid, how they're getting paid, why they're getting paid, and we really do need to have I just think ACA was the wrong direction to go on that, but
I agree.
We need to have an ongoing effort to try to come up with a better system.
I'd love to talk with you more about it, especially on the HSA things, because HSAs are actually causing more harm than good. And while you can afford your out-of-pocket, most of America can't. And we didn't give them the tools to shop cost and quality. So even though they have more skin in the game, they don't have the ability to exercise their consumerism because they don't have the money to pay it and they can't get cost and quality. I'll be quiet till it's my turn.
Dave, I'd love to connect. So we'll make that happen.
Absolutely, we can make that happen. And sitting quietly, who's got some great insight for us is Dr. Rakesh Pai with Metro Health, and I want to loop him in to give us some insight. COVID-19's had a huge impact on healthcare providers, and so Dr. Pai, if you could give us some insight on what's happened to healthcare providers and where you see the future going, we'll open it up to you.
Yeah, if you could go ahead and advance my slide, Mike, that'd be great. So, you know, this is really what happened to us and probably the whole U.S. economy. COVID-19 was a vicious right jab from Iron Mike Tyson, as you can see here. And, you know, everyone has a plan until they get punched in the mouth. You know, I think we were caught somewhat flat-footed. We're thinking the virus would stay over in China or Singapore or Italy or wherever we thought it would be. But, of course, it found its way here. And it was a significant shock to the system. How about next slide? This is the actual invisible enemy, just kind of the molecular structure of it. Not many people have seen this, but this came from the New England Journal of Medicine. The one thing I would say around 6 o'clock, there's this thing called the spike glycoprotein S. You can see that there. That's the docking mechanism by which the virus actually attaches to human cells through the human ACE2 receptor. And it's like a space capsule docking with the International Space Station. It gets inside the human cells and starts to use the cell's own replication machinery to kind of replicate itself. This is a very virulent, very infective virus. It remains a very serious enemy and a very serious threat. Okay, next slide. I think these things are really, really important. The COVID-19 key takeaways, masking, face masks. Unfortunately, this has been somewhat politicized recently, but face coverings really do mitigate the likelihood of getting this virus. So it remains a very, very important treatment strategy. Obviously, washing the hands more vigorously, the 6 feet social distancing you guys have heard about, cleaning the surfaces remain important. Just know that, you know, we continue to build testing capacity. We're anticipating a kind of scary fall when there's going to be other respiratory pathogens in the environment, such as influenza and things of that nature. So continuing to build testing capacity, continuing to follow the percent positives, continuing to do contact tracing. There are certain countries that do this better than us, like China and Japan and Korea, for example, and Singapore. But that remains an important thing, is finding the people that have been potentially interacting with someone who's infected. And just for treatments, we, you know, compared to now, as compared to a couple months ago, we do have an antiviral in remdesivir, which is that Gilead drug. Steroids are helpful because of the intense inflammatory response that this virus elicits in the body. And then convalescent plasma is really important treatment as well. And Metro has participated in that study. You know, just to remind everyone, HIV's been around for almost 50 years and we have no vaccine. So we have a lot of, you know, hope for a vaccine, and we got 100 different compounds in testing. But this virology stuff is complex, so there's just no guarantee, and we're, you know, fingers crossed, we're very hopeful. But remaining, you know, the things off to the right on my screen are, you know, we shouldn't get with very large groups. You know, we need to think about traveling on an airplane. You know, Delta said something to the effect that they won't pull passengers off a plane that don't wear a face covering. I'm not going to fly that airline. I mean, that's just my personal view on that, because I think that raises risk personally, okay? and stadiums coming to large stadiums for rock concerts or Michigan football games, you know, that seems a little precarious at this point in time. Okay, so next slide. So who's Metro Health? You know, we're a nimble, high-quality, differentiated organization here in West Michigan. We're affiliated with our parent organization, the University of Michigan or Michigan Medicine. We've become very good with virtual care in a short period of time, from having done very little in January or February to having done a lot. Since then, we are really looking to be a great community partner and connector to at-risk populations. We do have a direct-to-employer insurance product that I'll speak briefly about. We also have a COVID-19 consulting practice to try to help employers bring employees back safely to work, because I know that's a big concern. We also are partnering with educational institutions such as Aquinas College, Grand Valley State, potentially others. And we are believing that COVID-19 has staying power, and it's likely going to be in our vocabulary for the next 2 years, and we're preparing for that reality. Next slide. From 6 months, lots of things have changed. You know, we had a record high, a record low unemployment rate, 3.5%, 4%. You know, employers were really about, let's maximize benefits, let's attract and retain high demand talent, let's offer infertility benefits, things of that nature, to now, you know, 6 months later, 15% or so unemployment rate. Some people think that could go higher to 20%, hopefully not. I applaud the congressman and for that bipartisan efforts to kind of revive the economy. I think it's going to, you know, work its wonders shortly. There's flickers of hope as we see. But now it's really about the employers are asking, what's the opportunity to achieve savings on healthcare dollars? Profit growth has definitely slowed. Okay, next slide. So this is what happened to us at Metro Health. We were doing about 5,000 ER visits a day, 4,500 in February, and then that dipped at the sort of the nadir of the crisis at around 2,600 ER visits. And just to get, so you guys have some sense, we end up admitting about, you know, 10, 12, 15% of our patients that come through our ER get admitted to the hospital. So you see as ER visits go down, hospital admissions will go down. So you can see there's been a significant downtrend. Part of that was this pendulum. We kind of confused patients, you know, that it was continued to be safe to come to the ER if you had a myocardial infarction, a heart attack, or a stroke, or something of that nature. So unfortunately, some people had those conditions at home and suffered bad outcomes because they were afraid to access the healthcare system. Things are starting to rebound a little bit, but still remain depressed. Okay, next slide. If we look at our face-to-face visits, we were doing about 45,000 face-to-face visits each day, about 2,250 visits each business day. And then you can see from a virtual care perspective in yellow, we were doing very little, 0 of those visits. And then in March, when we kind of shuttered our clinics because we were worried about this tsunami wave of COVID cases, we started to turn on our virtual platform. And at our peak, we did about 10,700 visits or so. We always continue to see some patients in the clinic. Imagine if you had cancer diagnosis, a surgical follow-up, or were pregnant, we continue to see those patients. But face-to-face, large in part, has bounced back, and virtual continues to be, 5–10% of our total visits, something in that range. Okay, next slide. So these were our challenges. You know, we had to reduce elective surgeries and procedures due to the governor's executive orders. I think that was the right strategy. The east side of the state was getting pummeled. Fortunately, out here in the west side, it was that we weren't as impacted by COVID-19. We thought we were going to get a lot of patients with COVID-19, but in West Michigan, across the 3 hospital systems, I don't think we ever breached more than 100 hospitalized patients with this disease. So, but preparing cost a lot of money. We had to call for extra hospital beds, ventilators, PPE. Hospitals do not have large warehouses to store equipment, supplies, and things like that. We keep them in relatively small closets, so that was a total change for us. While this virtual care was the primary modality, it traditionally does not reimburse like face-to-face care. I know CMS and a bunch of other payers sort of made them parity or at parity for this window. We don't know if that's going to be the case on a go forward. And then certainly rising unemployment means in this country, when you lose your job, you lose your healthcare benefits typically, which means for us an increase in self-pay patients, which is precarious because we have a very low operating margin business. We have high fixed costs with supplies, implants, pacemakers, defibrillators, and labor are very, very expensive because it's very skilled in our industry. Next slide.
Dr. Pai, real quick, a follow-up question for you. So you mentioned reimbursement rates for virtual visits, and right now CMS, Medicare, Medicaid are reimbursing at the same rates as in-person visits. That's something the Congress can take away to see if that can we can retain that model moving forward. But for the employers listening that have self-funded medical plans, they can choose to reimburse virtual visits at any level they want. And to your point, virtual is here to stay and something they may want to consider, correct?
Yeah, I think from the employer perspective, virtual visits for the right kinds of care make a lot of sense. You can reduce absenteeism. You know, employees can do that on a break or do it outside. I think there was a lot of burdensome regulation around telecare that made it kind of challenging, like the physician had to have a license where the patient was. I think that's burdensome. Some of the rules said the physician had to be in a clinic to offer a virtual visit. So I think hopefully those burdensome regulations will sort of melt away. And it would be great from my perspective if virtual care was reimbursed. Maybe it doesn't have to be penny for penny, but if it could be 80%, something like that, 85%, that would probably be acceptable for us because we know it's an important way to deliver care and it works well for certain types of care. But good call out, Mike.
Perfect.
So what happened pre-COVID, I'd say employer groups that pay, healthcare systems that deliver care, and health plans that kind of interact between the two were kind of in an equilibrium, but with this COVID shock, there was a healthcare crisis. You can see the chasm here. The health plans were really the large winners here, frankly, because you know, a lot of care wasn't delivered, electives were canceled, ER visits, you saw what happened, face-to-face visits, you saw what happened there. So the health plans ended up doing well, you know, sort of at the expense of these other two stakeholders, the healthcare system and the employers. And I will say that we're still very concerned about the next COVID wave. We still believe we're in the first one, and we're very concerned about fall 2020 when we're going to also have influenza and COVID-19 out there. It could get kind of tricky to figure out what's going on, and there could be higher risk with co-infection. You have people with both these viruses. Could be a very bad outcome. Okay, next slide. So what are the realities? You know, face-to-face visits went down. You saw that. Elective surgeries and procedures also went down. You know, probably through this, all these public announcements that we were making, a lot of patients became very, very hesitant to return to the healthcare system. We continue to be worried about the multiple waves. We are very concerned about patients that delayed care, became sicker, and had a poor outcome. That was really, really unfortunate. We have many examples of this in our health system, and I'm sure that's throughout West Michigan health systems. We really struggled to procure mission-critical PPE. This is kind of, you know, basic blocking and tackling, and you can imagine if our people don't feel like they have the right equipment, their willingness to put themselves on the line goes down. So we had to address that fear and anxiety amongst healthcare workers, and many healthcare workers unfortunately ultimately tested positive for this disease. The testing capacity was also a struggle, again, caught flat-footed. You know, we couldn't get enough testing capacity quick enough. I think we're in a good spot. We're going to continue to ramp into the fall because we're concerned, and we remain very hopeful about all the vaccines that are potentially in development. So fingers crossed on that. Next slide. So our direct-to-employer effort, you know, is called MetroCare. It's a hard dollar claim-saving product, very competitively priced. It's priced at some multiple, relatively low multiple of Medicare. It is not a narrow network, but a tiered network, meaning that if you achieve all of your care at Metro Health, our 17 ambulatory clinics, the University of Michigan, and our Children's Hospital Mott, you can achieve significant cost savings. But you do have to travel for some of those treatments. The VOS, so to speak, wouldn't be appropriate for this type of a product because it's in a higher tier, and therefore there wouldn't be the significant savings. But it's an opportunity to engage employees and members. It's much reduced out-of-pocket costs because overall the healthcare costs are quite low. We do very well with population health management at Metro. It's something that's in our DNA, and we are very good, like I told you earlier, at doing virtual care. Next slide. So our partner, just a few words, you know, number 11 rated health system in the United States, very strong in many of these things. A lot of their specialists are seeing patients out here in West Michigan. We're really sort of turbocharging our affiliation with the University of Michigan, and we couldn't be any more thrilled to be associated with them. Next slide. So some other components about how we serve employers. You know, I think the ideal MetroCare employer group would be something relatively small to medium-sized in the 50 to 500 employer range, predominantly located in Kent County where we are. We have excellent primary care access. Our primary care practices do not close. A lot of times you can even get same-day visits in person or virtual. Again, it's that streamlined claim savings process if you use the Tier 1 network, and there's a number of other different things that we're doing here that I won't go into. But quality really is at the heart of everything we do here at Metro Health. Next slide. So how can the legislative branches potentially help healthcare systems? And Bill, I really appreciate you being on the webinar. I think regular and transparent communication and connection with all relevant healthcare stakeholders was really needed. I think when the crisis hit, we all got into this sort of silo mode, but we need health plans, hospitals, government, state and federal agencies, employers, and pharmacists, sitting at the table and sort of developing this playbook together. It took us a while to find our footing. I know the hospital, once the electives turned off, that was a really dark day at Metro because that's really where our bread and butter is, for sure. So connecting, convening, cooperating, really, really important. And then I would just put a plug for procuring and manufacturing mission-critical PPE. Some of that's probably got to be made in the United States. You can tell that when the world is going through this shock, right? China started being very nationalistic. They're the supply chain for the world. They were commandeering all their PPE for their own situation, which I understand. But we need to manufacture some of this stuff here so that we can have it when and if this happens again. And all likelihood is there's going to be more of this in the future, right? We really need to remove burdensome regulations for virtual care. I kind of talked about some of that. And if we could get to near parity reimbursement for virtual care, that would allow it to continue to flourish like it did at sort of the height of the crisis from our perspective, which was April. Okay, next slide. I also think one of the things that's very, very clear to me, and I think this is my last slide, is that the virus and the economy have to live in equilibrium, right? We can't just shut down and put the economy in a coma. And I think in order to have those two live in balance, we really need to invest in strong public health departments and strong public health measures so that we can be more surgical in how we shut down communities or parts of our economy. And that is contact tracing. If you have a super spreading event or something's really torching up in a certain neighborhood, you really need to be able to contact trace and isolate that sort of area rather than shutting down all of Grand Rapids or all of Wyoming or all of Holland, right? There's ways to be a little bit more surgical rather than using a sledgehammer. And then I think one thing that's really important is the healthcare disparities, which I find very, very tragic, is that this virus has disproportionately impacted the Latinx community, the Black American community, way more than the Caucasian or the Asian communities. And equality and equity are different things, which means at times we have to help other populations out a little bit more than others because they're disproportionately taken advantage of. So with that, I'm gonna stop. I appreciate the opportunity to talk with you all.
Awesome. Dr. Pai, thank you so much for your insight. We're going to dismiss Congressman HUIZENGA. He's got to hit the road. His phone's already talking to him and spitting out directions. He's got a 10-hour drive in front of him. So with that, we're going to turn that over and take your transition and turn it over to David Contorno. So you mentioned we need to have a lot of folks and stakeholders around the table to find the next solution. And David's going to talk about how employers can really have a seat at the table, which they haven't had before. David?
Perfect. Thank you.
Hey there. Okay. Thank you so much. Dr. Pai, first of all, I want to thank you for your service, for the front lines. I mean, you guys, first of all, you've been beat down by our healthcare and health insurance system long before the pandemic occurred. And since then, you've been asked to put even more forward and put yourself in more risk and more danger. And I don't know of a single healthcare worker that hasn't done it. So thank you, thank you, thank you, first and foremost. I know, what's my time like, Mike? Give me a quick.
So we got 20 minutes left. We might run a little bit over. So I'll give you about 18 minutes and I'll try to wrap it up with 2 if that works.
Okay, so I'm going to go really quick. And what I really want to talk about first is some of the problems before we get into some of the solutions. And here's some of the problems. This graph represents in the orange bar what premiums have done, and in the blue bar what wages have done. We all know premiums are out-inflating wages, right? We know that. I don't think I need to do that. But let me show you the slide that really kills me. This slide shows what deductibles have done. So while the congressman was talking about HSAs and how he likes them, and I appreciate that, and I speak to employers all the time, who like HSAs. You know why? The employers I'm speaking to make $200,000, $300,000, $400,000 a year. It's easy for them to fund an HSA. But what about the worker who makes $35,000 a year and has a $10,000 family out of pocket? They are literally a bad stub toe away from bankruptcy. And we know this because the #1 cause of bankruptcy in the US is medical bills, but nearly 3/4 of those people that file for bankruptcy because of medical bills had health insurance. It's not the medical bills that are bankrupting them. It is their share of the medical bill under their health insurance plan. Not to mention, cash pricing, as I said to the congressman earlier, is usually the lowest price because doctors and hospitals have to wait months and months and months to get paid. Then they have to chase down the members for their out-of-pocket. It's getting worse and worse. So let's talk for a second about what most employers do to mitigate this. They switch from carrier to carrier or from HMO to PPO or high deductible health plan. Well, let me ask you guys a question. If you had a car payment that was too high and a car that was too low quality and was breaking down all the time, would switching from Allstate to Geico lower your car payment? Or would raising your deductible on your car insurance, would that lower your car payment? No. And changing insurance and changing how you fund insurance and changing carriers, that doesn't do it either. So let's talk about some of why. The first problem is, and I say this all the time, our healthcare system is not broken. People say it's broken. It feels broken, but it's not broken. It's working exactly as it was designed. The problem is it wasn't designed by employers who put the bill, doctors who provide the care, or patients who receive the care. It's not working well for those three entities, but guess who it is working for? The traditional broker, not the Mike Hills of the world, but the brokers who work predominantly on commission. That is how most brokers are paid. When a broker is paid on commission, guess what happens when you as your employer's rates go up? How much money they make goes up. So even if they could save you 40% on something, why would they do that when it's going to give them a 40% haircut? So one of the things that we teach through organizations like Mastermind, which Mike is part of, is how to realign that compensation. So the way we get paid with our clients, for example, is, and I'm going to show you an example of that at the end, is we get a flat fee every month only from the client. We get no money from anyone else ever. And we set a bunch of goals, usually tied to lowering costs. And if we hit those goals, our client pays us the bonus. Right now, your broker is most likely being paid by the carrier and being bonused by the carrier when they do what it is the carrier wants them to do. So the first thing you need to do is change the way your consultant or broker gets paid if you are an employer. And I promise you that if they don't know how to be effective at achieving your goals, they're not going to be willing to be paid in that manner. The next thing I want to talk about is the PPO network. Now, we spoke about the PPO for a minute with the congressman. Let me tell you what a PPO is. A PPO network is a contract between a hospital or a doctor and an insurance company. It's a confidential contract. If you asked to see that contract, you wouldn't be able to see it. Even for a self-insured employer like Jill on the call who said, we're self-insured, we still have no insight over costs. You know why? Because we have a network. And when we have a network, we sign a contract that says we'll pay whatever the network tells us to pay, but the network isn't going to tell us what to pay in advance. They're not going to tell us till afterwards. We have access to a lot of information, and I didn't intentionally do this, but I want to show you how good Metro Health is and where Dr. Pai works. This is a chart of the hospitals in Kent County, Michigan, the 3 hospitals that report. Now, I've omitted the names, but what I've done is I'm looking at all inpatient average quality, and I am sorting them by highest quality on the left and lowest quality on the right according to Medicare. Medicare is the largest payer of healthcare in the country, and they track quality data across multiple metrics. Metro Health is the highest quality inpatient hospital in Kent County. As you saw, they're number 11 in the country. They're number 1 in inpatient quality in Kent County, Michigan. Now, there's 3 bars for each hospital. The orange bar represents what it costs them. So every year, the hospital has to report to Medicare, what does it cost you on average for an inpatient stay? The blue bar is what Medicare reimburses them. And the green bar is what they bill Blue Cross, United, Cigna, Aetna. Now, one of the things that I checked with Dr. Pai before we did this meeting was, especially with their direct-to-employer model, what is their payment methodology? And you want to know what their payment methodology is? The same one that we use in most of our plans. They're going to look at what Medicare pays them. Now, as you can see, Medicare underpays them, so they're going to mark that up slightly, but they're going to pay a markup of Medicare instead of the traditional insurance and traditional hospitals, which guess what? They pay a mark down of whatever they decide to charge. So the contract in the PPO says to Blue Cross, Metro Health will give Blue Cross a 30% discount on everything they bill, but you know what's not in that contract? The starting price. Metro Health can bill whatever they want. And I feel really bad for doctors, especially like Dr. Pai. You know why? Dr. Pai has a patient that comes in. They need a stent. They need some sort of heart surgery. He's a cardiologist. So he says, let's go ahead and do it. You have good insurance, so they're going to pay for the bulk of it. But guess what? What he doesn't know is they have a $10,000 deductible. And what he doesn't know is that hospital is going to go after them for that $10,000 deductible. And some hospitals, I don't know Metro for sure, but I know of many, sue patients when they can't afford the $10,000, even though they may have gotten $80,000 on top of that, way above their cost. And I feel really bad for these doctors who are unaware that their medical advice is unleashing this world of financial hurt, often bankruptcy, or even worse, they're giving advice that even with health insurance, they can't afford. And a lot of doctors claim, well, I don't want to know the finances of medicine because I don't want it to taint my advice. But what good is giving a diabetes prescription to a diabetic when they can't afford the medication? You might as well not have given them a prescription at all. I want to show you guys one other thing, especially if you're in Michigan. This is looking at DRG 470, which is a lower joint replacement without major complications, like a knee or an ankle. Even though they were ranked number 50 by Dr. Pai's own admission, they are still the highest quality orthopedic hospital, at least general hospital, in Kent County, Michigan. So if they're going to pay a price based off of this, and they're the highest quality across the board, and everyone is going to pay a price off of these green bars, everyone else, why is everyone not going to Metro Hospital for the things that they're good at and have reasonable pricing? Well, I'll tell you why. If you have Blue Cross and Blue Shield, they are prohibited from sending you to Metro Hospital and saying, go there and we'll cover more because it's better and costs us less. You know why? Because there are other hospital systems that are bigger, that have more patients and lower quality, and they say to Blue Cross, if you steer people away from us, we won't be in your network at all. So they're prohibited from doing that. It's one of the reasons why in our plans, we completely get rid of the network. We go to the doctor and say, what's the fair price? We'll come up with a fair price. Here goes a patient. And obviously we don't do that in emergencies, but if a knee surgery can cost $14,000 or $80,000, and typically the $14,000 place is the higher quality place, why would we not create plans that say, go to the $14,000 higher quality place and your employer will pay 100%, because for them, it's better than paying 80% of $80,000 where the outcomes aren't as good, or where more unnecessary procedures occur, where orthopedic surgeons say, you know what, surgery might help you, but physical therapy might help you too, so why don't you go try that first, and if that's not effective, then we'll look at surgical options. But most surgeons don't do that. Most surgeons say, surgery will probably fix that. I'm a surgeon, it's what I do, it's how I get paid. To a hammer, everything looks like a nail. To a surgeon, not all surgeons, but to many surgeons, everything looks like surgery, and that's what they're going to do. And we know it's particularly egregious in orthopedics. It used to be in cardiology. For those of you that know the book With the Price We Pay by Dr. Marty McCary, he talks about how cardiologists were overstenting hearts. They were doing it when it was unnecessary. It was very profitable. And the board of cardiology actually came down on them and said, this has to stop. So you know what they started doing? They started stenting legs unnecessarily. Again, not Dr. Pai, I'm talking about doctors in general, but the incidence of leg stents went up dramatically because they didn't want to lose that revenue. Our system is profit driven. Even the nonprofit hospitals, the nonprofit health systems are profitable. And let me show you profit. This is super important, guys. I want you to understand how insurance companies make money. I'm going to ask everybody on the call this question. Let's pretend that I run United Healthcare. They are the most profitable. They are the largest health insurance carrier in the country. Let's pretend that I run United Healthcare just for the state of Michigan. I'm the CEO of Michigan, okay? And right about now, I have to get ready to report my costs for my rates. I have to get them filed for 2021. So I have to go to my actuaries and say, hey, actuaries, how much do you think everyone in Michigan on a United Healthcare plan is going to spend in 2021 on medical and prescription costs? And let's pretend they come back with a number of $850 million. So I say, okay, I'm going to set my premiums to be $1 billion around the state from all the United clients around the state, so that I bring in $1 billion. I have $850 million to pay the doctors and the prescriptions and the hospitals, and it leaves me $150 million for my overhead. And of course, I have to send profit back to the mothership. They're a publicly traded company. What happens if in 2021 something miraculous occurs? You know how all carriers have cost containment tools? Let's pretend in 2021 those cost containment tools actually work. And instead of $850 million, United Healthcare only spends $425 million on medical and prescription costs for everybody on one of their plans in Michigan. Now, they still collected $1 billion in premium, right? Because that was preset. Your premiums are locked in for a year. But they spent half as much in claims. How many of you think United Healthcare's profit goes up in that situation? Now, I can't see most of you, but I ask this question of CFOs all the time, and every single one of them says, well, if they anticipated $850 million and collected $1 billion and only spent $425, then clearly their profit went up. No, that is absolutely not true. Not only did their profit not go up, but it got cut in half, their revenue and their profit. And here's why. There is a provision of the Affordable Care Act called medical loss ratio. And it says that every insurance company must spend 85 cents of every dollar they collect on healthcare costs. So if they collected $1 billion and only spent $425 million, they were only at a 42.5% loss ratio. So they have to return $425 million worth of claims they didn't spend, plus $75 million of their overhead and profit. So what happens is, here's a very simple example. If in 2014 they collected $1 million worth of premium, they have to spend $850 million in claims in order to keep $150,000 of overhead and profit. If they promise their shareholders $165,000 next year of overhead and profit, the only way to get there is for claims to go to $935,000. And the following year, if they promise their shareholders more, the underlying claims has to go up yet again. So remember, a publicly traded company has obligation to one entity and one entity only, and that is their shareholders, not their customers, not their patients, not their employers, their shareholders. So literally, if they were to lower healthcare costs, they would actually violate their fiduciary responsibility to their to their shareholders. So for any of you who are with a Blue Cross, United, Cigna, Aetna, or any carrier, you will never have decreasing costs. You literally can't. You might have 1 year where the rates come down a little bit. But I want to show you something even more telling. I assume a lot of people here are in Michigan. This is an article from March of this year, March of 2020. And what it says is, it says Blue Cross and Blue Shield of Michigan reports higher earnings for 2019. Then they say down here, because of that, we are moderating or lowering our health insurance rates for individuals, small employers, and seniors. Now, Mike is in Michigan. He has some clients with Blue Cross and Blue Shield. I asked him before the call, did you have a single client whose rates went down? And you know what his answer was? No. And for any of you with Blue Cross and Blue Shield, I want to ask you, did your rates go down? They're claiming they made money. Their earnings were higher. They were going to return it to you in the form of lower premium. Did it happen? No. But we believed it. We stayed with them. We kept allowing them to insure us. The stuff they spin is absolutely unbelievable. I'm not even going to go into prescription drugs. If healthcare is profit-driven and non-patient-centric, what happens on the drug side makes healthcare look like Mother Teresa. It is a shell game of telling doctors which drugs to give their patients, not based on what's clinically appropriate, but based on what makes the pharmacy benefit manager the most amount of money. I guarantee you that Dr. Pai has tried to prescribe medication that he felt was best only for his patient to say, my insurance doesn't cover that, it covers this other medication. And maybe he doesn't understand why, but it's almost always because somebody's making more money on that other medication than the one that he recommended. So what are the solutions? Because that's really what we're here about. The solutions are, first of all, you have to be partially self-funded. And being self-funded is not any riskier. It's not. You can be more riskier if you want it to, but we can actually make it less risky than fully insured, and Mike and I would be happy to educate you on how that is. We build a plan that has no network of providers. We pay most of our doctors what Medicare would pay them, which almost every doctor accepts, with a huge markup. And so instead of this bottom-down approach where the starting price is set by the people we're paying and the discount is set by the insurance company and we have no control, we take a known starting price and we mark it up. And we say, this is what we're going to pay the provider. But we have something even better. You see, there are lots of doctors and hospitals across the country that publish their pricing. Surgery Center of Oklahoma is a great example. If you go to Surgery Center of Oklahoma's website, Dr. Keith Smith, who opened up his doors in 1993, he's never raised his prices. As a matter of fact, since 93, he's had 4 price adjustments. They've all been down. On the homepage of his website is all of his costs and all of his quality metrics. Now, I'll give you a quick financial example. I needed an inguinal hernia surgery, just, a groin, normal hernia, middle-aged guy, working out, I got a hernia. My local hospital here in Charlotte, North Carolina, here was the price after the Blue Cross and Blue Shield discount, which is what I had at the time. It was $8,900 at the low end. It was $47,500 at the high end after the Blue Cross and Blue Shield discount. Now, the $47,000 place is the place that everyone here in North Carolina thinks is the best. But it turns out that at least as it relates to hernia, they had the highest complication rates, the highest infection rates, the highest readmission rates, and they were the only one of the 4 hospitals in the area that had a death because the patient acquired a hospital-borne flesh-eating bacteria, and they were the most expensive. But I didn't go to any of those places. Instead, I flew to Oklahoma. I put my Blue Cross and Blue Shield card aside. I paid full price for the surgery, which was $3,060. So when you add in the surgery, the hotel, and the airfare, I was at $4,000, which, by the way, was thousands of dollars less than just my deductible and out-of-pocket would have been had I gone. So to Dr. Pai's point earlier, I know people that would drive from Charlotte to Atlanta, which is 4.5 hours, if the car they wanted was $100 less a month at a dealership in Atlanta, but they won't drive 45 minutes to get much higher quality healthcare at a lower price. We need to start to think differently. So in our plans, we say to employees, there's no network, so you can go wherever you want. But we have access to cost and quality at providers around the country. And if you allow, and usually they're local, but not always. And if you allow us to steer you, help you get to the doctor that has the best outcomes, the lowest complication rates, the most experience in what it is that you need, then your plan's going to pay 100% of the cost. Because think about my hernia surgery. If I'm the employer and my plan is footing the bill, would I rather pay 80% of $47,000 and leave my employee owing $9,000 that they'll never be able to pay at a lower cost facility? And more importantly, then the hospital has to chase that member down for $9,000, which they're collecting on less and less and less. Or would my plan rather pay 100% of the $3,000, even pay for travel when necessary, and leave my employee owing nothing at a place where the outcomes are much more likely to be much better? That's the way we do it. So we do it in multiple ways. Direct contracting. That's part of what Dr. Pai was talking about. Yeah.
2 minutes left. So,
okay. We can contract directly with facilities like Metro Health who are willing to give fair pricing models, who we know have high quality work, and then we can steer people there by completely waiving the out-of-pocket, which is great for the hospital because they're collecting less and less and less of member responsibility. So they get paid in full by the plan, the member gets no out-of-pocket, and they get higher quality care. We also believe in bundle pricing. Doctors that are so good at what they do, they're willing to say, hey, I'm going to charge you $15,000 for your total knee, and if there's a mistake, if there's a complication, if there's an infection, that's on us. We're not going to charge you any more for it. That is a doctor who is confident and a hospital who's confident in the work they do. Couple of quick case studies just to show you how powerful this is. So these are a few clients. This one was a larger client, 7,200 employees. They were spending $80 million on 7,200 employees. When they became our client in 2016, at the end of 2017, we had brought that $80 million down to $61 million, by the way, on a 10% larger population. And then at the end of the following year, we brought it down to 45% savings. So now $49 million on, again, a higher population.
Awesome. And David, I'm gonna have you hang it up there just to make sure we hit our timeline. I appreciate your comments very much. I've just got a few additional things that I want to share with the group, and we'll wrap this up and stay on time. So a couple things that I just want to drive home to all the folks on the call, especially the employers. The coronavirus has changed everything about life. If you think about any aspect of your life, it's probably changed. For example, your work is probably different than it was before. When you go in public, people are wearing masks. You're likely wearing a mask when you weren't before. The fact is, life has changed. And so what we want to do is really drive that point home, and the consumer has changed as well. This survey from Gallup, what it outlines is that people are changing their behavior. In simply 2 months, from March through the middle of May, consumers changed their behavior in many ways. Getting takeout instead of going to restaurants, having their groceries delivered or shopping online, and using virtual visits with their doctors. Behavior has changed, and we need to capitalize on that. This is a recent survey from Kaufman Hall that points out that people, your employees, your plan participants are concerned about using healthcare. They're concerned about going to the emergency room. 50% of the people are either very uncomfortable or uncomfortable in going to the emergency room today. And so the point is, your employees and your plan participants are reacting to healthcare in a different way today. So what do you need to know about that? The point is, the coronavirus has given a once-in-a-generation opportunity to employers. Healthcare providers like Dr. Pai and his team at Metro are rethinking how can they engage with employers and their employees to help them be healthier and find a win-win solution that cuts out the middleman. Change has been the biggest resistance. The resistance to change has been the biggest barrier employers have faced, and everything has changed. So employers can change healthcare, and employees won't be surprised. The tight labor market that we were all facing has changed as well, and so employers have an opportunity to reinvent their health plan, working with partners like David and myself and others to really build a plan for the future. So a couple things that we want you to consider, employers. Number one, get engaged. As Dr. Pai illustrated, they are willing to have a conversation directly with employers to find a solution that works best for the healthcare providers and the employers and the plan participants. It is absolutely possible, as David illustrated, to lower costs and get higher quality. Leverage virtual care. We've had some employers implement behavioral health, mental health at 100%, even on HSAs, leveraging virtual care right now. They did it mid-year. Rethink your pharmacy benefit. David skipped over PBMs, but using narrow networks, cutting the big boxes, the CVS, the Walgreens, the Rite Aids out of the picture, rethinking what your pharmacy plan looks like. You can drive dramatic savings and impact a very small percentage of your population. As David pointed out, rethink your network. Do you need every healthcare provider in your area in your health plan? Why isn't your health plan steering people to the highest quality providers? As David pointed out, Blue Cross won't do that for you, and other carriers can't do that for you. They're contractually prohibited from doing so. So you need to have a medical management provider that's going to be a partner with the member, not trying to just rubber stamp stuff. Yes, it's covered. No, it's not. But hey, here's the right place to go, and here's why. And finally, consider building a new plan from the ground up that's best for you. There's lots of levers to pull, and if your current administrator is not letting you pull them, then guess what? You've got the wrong administrative partner. So I would just like to say a big thank you to Dr. Pai and David for joining us, and Congressman HUIZENGA. I'd like to thank you for joining us today, and we'll certainly follow up with you with additional information in days to come. Thank you, David, and thank you, Dr.
You know, Mike, and there is one thing I forgot to say that I specifically said I would. So for those of you that are still on, when we look to price a new plan, I don't care if it's fully insured, partially self-insured, it doesn't matter. One of the things that the carriers look at is your renewal. And the renewals that are going to be coming out, the carriers have already said the pandemic is going to make the renewals worse. Even though you're hearing mixed messages on that, like elective surgeries are down, carriers have already prepared for larger increases because of the pandemic. If a carrier, whether a self-insured stop-loss carrier or a fully insured carrier, uses your renewal to rate the new plan, which they always do, and you wait for that bad renewal to come, you are going to get worse offers than if you do it before that. So my encouragement is don't wait till renewal. Don't sit on it and say, let me see what happens. Start to look now. Healthcare and health insurance should be a multi-year strategy, not a 1 year or a 6-month strategy. And Mike can help you put together a strategy that mitigates not only whatever the pandemic caused, but all the other bloat and excess in the system. It's a doctor-friendly, patient-friendly plan that we build. Those are the only entities that we care about: the employer footing the bill, the doctor providing the care, and the patient receiving the care. Everything else is just noise and bloat.
Awesome. David, that's a great note to end on. Appreciate you all joining us today. Again, Dr. Pai, thank you for joining us and your partnership with Metro Health. Hope you guys have a great day.